So my background's not in healthcare, it's in investing, but probably about 2 years ago, I was invited to an event very similar to this, and just kind of sitting there and listening to others speak about this idea of the redemptive frame. And it was so encouraging for me because in my own walk, I was wrestling with what does being a follower of Jesus mean for me vocationally, and to know that there was others like me out there who were wrestling with that same question. And not only that, but there was an entire sort of framework and vocabulary around that. And so that's really the idea of this event, is to get the imagination going and give some semblance of a framework of what it looks like to be a follower of Jesus and what we do, where we spend the majority of our time for most of us. And so here we're talking about redemptive strategy. And for me, I like to keep it simple, but if we're using the exploitative, ethical, and redemptive framework, in the context of strategy, we're talking about imagination for the products and services that we put out into the world. And so, exploitative is this idea of leveraging culture. For me, a great example of that would be tobacco. You tap into this idea of something being cool, or a busy culture, and you create a product that is destructive and harmful. And so you leverage the culture in that way. And then there's this idea of ethical, where we're advancing culture, and so good products and services that help push people along. And so, I think of Zoom, right? Video chat, where we're advancing culture, where we're putting something out into the world that helps keep us more connected. But redemptive is this idea of renewing culture, going into broken spaces and creating products and services that turn the tide on brokenness. And with that, I can't imagine a better group of folks to talk about the idea of how do we have imagination for renewing culture with our products and services. So be great to get into it. And maybe we'll start for each of you with just a quick description about how you think about where you sit in the context of the healthcare industry.
Well, I spent about 30 years altogether in healthcare, generally in administration. And I learned very quickly that practice of medicine, inpatient and now outpatient, was largely framed by politics for how you get paid. I don't believe any consult was given to any medical person about what happens when people get sick and what do they need. It morphed very quickly over that time into the combination is sort of the law of unintended consequences. So they come up with Medicare in 1965, and it was meant to help old people access health care. In that period of time, most health care was inpatient, not outpatient was your primary care doctor, and that was it. There was no such thing really as outpatient surgery except for feet. And very quickly, things between that reimbursement mechanism, technology, and the need for doctors to be able to have control over their medical practice, things began to move very quickly to outpatient. So my grandfather, right in the 60s, had cataract surgery. It was in the hospital. He was in a hospital bed for several weeks with his head sandbagged. Fast forward 20 years, and my dad needed cataract surgery, and it was outpatient. He had it done. It was in a doctor's well-equipped clinic, and he came home. He had eye drops. That was it, and limitations on what he could pick up. That trend has occurred across the whole medical field. So reimbursement developed by people who are not medical continued to progress along, and was a need politically to get votes, so they start messing around with, well, how can we expand this? So they expanded it in lots of ways, and you can look it up, but essentially where we are today is we have an increase because nothing was ever done with chronic care. You know, if you have diabetes, what's the best way to manage chronic care? They don't reimburse for that well. So we have an increase in chronic care and an increase in acuity. So here I am in administration, and I'm trying to chart a relatively competent path for the hospital and for its doctors. How do we cure ruptured relationships? Because the powers that be in government thought that, you know, colluding with our doctors was a bad idea. Oh, really? I think our patients pretty much left knowing that they're there, but never mind. So we had to come up with different ways to make that work, and that's kind of the space in which I spent my time. I'll let
Thank you. Yeah. Reid, Cindy?
I feel like we covered a lot last night with what we're doing, but with mental health in general, I recently was traveling to another country where they're about 30 years behind us in the mental health space, and we were teaching about trauma, and the entire room of people, we were basically giving them permission to process and focus on trauma versus a diagnosis, and they were blown away by it. And so I was thinking, operating in the mental health space, I'm constantly thinking that I always say we're in the dark ages. We don't really know what we're doing a lot of the time, and so we're constantly searching for new trainings, new innovation. So mental health in and of itself, I feel like is in the beginning years of finding good solutions to meet the needs of our community members. And so Halo Project is in that space. We are innovators in that space, and we then share that across the United States and globe. And it's a lot of time spent with families and kids figuring out exactly what they need based on what they're telling us, and then sharing that nationally and globally.
Yeah. I think, like Cindy said, I shared a lot last night, but maybe the two things that come to mind thinking about this right now is I've never really, if you work in healthcare and you understand the hierarchy of hospitals and physicians and stuff like that, pediatrician, right? We're at the bottom of the totem pole. And I've never really been that smart, never really been that strategic, I don't think. There's just a couple of common sense things that I think we've sort of had the advantage at Hilltop of saying, like, let's start there. And the two things are, didn't we all go into this to care for people? Yet over and over again, we find ourselves in systems that don't seem to care for anyone except for maybe someone at the very top, or some dollar sign, or some requirement, some checkbox, something like that. And so we literally, when we started, I was finishing residency, and I was looking around at all of these physicians that were 30 and 40 years older than me, and looking at all of them leaving their practices, leaving the hospital, and what were they doing? They were going into charitable clinics and saying, we just want to serve the people that are in need. And so really, like, the super strategic move was like, let's just skip 40 years. Let's just do that. Where the strategy had to come in is like, how do we actually feed our children if we do it that way? And then the second thing I'll say is that, to what Cynthia was saying, is that our model has sort of accidentally or maybe intentionally been flipped on its head, that we're not a healthcare model. That is not the natural trend of the model right now. We are a sick care model. It's de-incentivizing healthcare and very much incentivizing sick care. And I think at Hilltop, what we're trying to figure out is, and I'm a primary care doctor at heart, but we're trying to figure out how can we shift that emphasis in a way that both is meeting the obvious need in front of us that people are asking for, but I love it, I say this all the time, I love it when the right thing and the selfish thing are the same thing, because then you don't have to convince people to do it. And the system selfish thing would actually be to have healthcare, because sick care is way more expensive, it's way more frustrating, and it's way more overwhelming for the system. And so we're, again, just trying to shift that focus of how do we, earlier in life, and more focus on health, and then take care of the sick as we need to.
Well, I think the great thing about this panel and this representation is, if you think about administration and primary care, you imagine at some level you probably, doctors somewhere started on the ethical sort of, vector, and then, over time, what I hear you describing is potentially a bleed into exploitative, maybe in some cases intentionally, in a lot of cases probably unintentionally, the bureaucracy of the system, and then Cindy, you operating sort of on the cutting edge of a lot of new understanding and evolution. And so where in some ways what you're talking about is going back to first principles, and you're sort of thinking about the creativity and the understanding. Well, I guess, Cindy, for you, in that context, being on the cutting edge and being at the early stages of understanding, what do you see as some of the most sort of redemptive possibilities in terms of strategy and products in your space? I think
product-wise, the mental health space and redemptive strategy line up very well if somebody's open to it and going into that space of caring for people on a servant level. Oftentimes, we are showing up in the missionary space with our children and families and clients. So I think it's easy to be redemptive if you are coming into it with a servant heart and a mission heart, because there's so many opportunities to go above and beyond the billable hour with children and families. And so I think sometimes we then get up against some traditional ways of doing counseling and bringing someone in 1 hour and then maybe even bringing someone in 1 hour, making sure that we have the capacity to lean into that 1 hour, but then also the stuff that goes outside of that our clinicians are being asked to do. I think there's a lot of potential training opportunities. I know we at Halo Project do train mental health professionals all over, and part of our trainings are designed for redemptive framework. So they see us, we don't have pizza from boxes, we have a nice lovely meal, we have snacks, we have fidgets, every need is met, we have blankets for them. They can special order drinks from the 7-Eleven and someone will go get it. They are watching the kids and families come in, how we greet them, how we talk to our kids and families. Just the other day I was riding up the elevator with a new family and there was a child there, and he got off the elevator and I was like, okay buddy, have fun. And I was like, why did I say have fun when we're going into an hour of trauma counseling work? And the reason I said that is because this family is going to go by the kitchen, they're going to pick a snack, they're going to open the fridge, they're going to get their drink, they're going to pass scooter parking, Razor scooters where they ride all around the building. The lemonade stand is over there for them. The parents get to rest. The parents also open the fridge. And so we get to model that to other mental health professionals that come into our space and in our building. And I think a lot of it just takes permission to go outside of what it's traditionally been for clinicians, and to know that they can operate with more of that personal service of meeting needs versus just this 1 hour. But they have to have permission for that, because our ethical training doesn't give us permission for that.
Yeah. Makes sense. Yeah. And I think what you're kind of alluding to is bumping up against some of the systems at play, and I guess it's kind of a good segue. Maybe Reid, we'll start with you. What do you see as the risks of, again, unintentionally bleeding back into the exploitative sort of way of doing things within the context of what you do?
Yeah, I think to sort of piggyback off of what Cindy was saying, I think that a lot of the things that a lot of the practices that we find ourselves in, maybe even like a lot of the ways we were trained in kind of this ethical framework, it's like you're not allowed to ask the question, but what if I sacrificed? Or what if we gave up something? I mean, just a very simple thing that we're trying to work through right now and trying to figure out. We see our payer mix is the exact group of payers that everybody comes with. So we we have 65 to 70% of our patients are on Medicaid, 25% of our patients are completely uninsured with a very low out-of-pocket cost, and then about 5% of the people that everybody's going after in private insurance. That group of people no-shows their appointments all the time. Like that makeup of people no-shows all the time. And it's I can remember from the very first days of residency, sort of the begrudging conversations and how do we get these people to do what we want them to do, and how do we, and we feel that when you go to serve, the reality is you are more likely to be taken advantage of because you're opening your hand. No one can take something out of the closed hand, or not, unless they're stronger than you. But if you open your hand, people are going to take things out of it. But we just begin to ask the question, but what if we were fine with people being late? Like, what are we losing if they're late? What are we losing if we have things waiting for them to greet them that they might take more of than we ask them to? And what we begin to process is that actually one of the things at the heart of the system here is that it's a scarcity mindset. It's that we're afraid that we'll lose something. It's sort of built in that we're afraid there won't be enough appointment slots. We're afraid there won't be enough money. We're afraid. And so instead, if we just said, hey, we got what Jesus deserved, so that in order to do that, he got what we deserved. So that is an abundance of grace. So what if we did the exact same thing within our system? How do we hold the healthy boundaries? How do we love people that are after the person that is late? Like, those are the complicated questions, but I think just asking those questions, and a question that I've had in my mind a lot when we talk about these kinds of things is, why can't we? Whatever it is that we're saying, well, we can't do that, why can't we? Is it because it's exploitative to do that? Okay, then we shouldn't do that.
Yeah.
But is it because we have something that we're trying to protect? We might want to ask, should we unprotect that?
Yeah, it's good. Cynthia, what do you,
So my role, I'd walk into the doctor's office. I'm from administration. That was not a happy thing to say. But my role was to try to protect the relationship between the hospital and the doctors. And you cannot underestimate the extent to which the reimbursement system is exploitative and forces doctors, hospitals, everybody involved to not necessarily do the right thing because of the way it drives what to do. It's based on an insurance model, which is stupid because insurance is a guarantee that you're covered in the event of an unlikely thing. Well, bad health is not unlikely. And that's the first place where it's split. Originally, hospitals were formed in this country mostly by religious organizations. And there was a social contract between the doctors and the hospital and the community that care would be provided. It was a very ethical model. Then comes all of these structures without any input as to medical practice that drives different responses. We used to give classes to our doctors on ICD-9 codes as they came out and how to be able to structure their practice so they get fairly reimbursed. It destroyed the relationship. We used to be able to pay doctors for extraordinary service, like in the emergency room or whatever. We used to be able to help facilitate relationships between referring doctors and specialists. And you can see what's happened. So when I started, we started as a strategy employing primary care doctors to help feed our specialists. And now they employ specialists so that the ER gets covered. And it's just a crazy model. So how do we go back to that? I think to understand that we're common elements in this issue of reimbursement. And it creates a very difficult economic model. Increasingly, there are some new choices about how to cover insurance, how to practice within that environment, and I hope that grows because it gives everybody some ownership in terms of being able to direct care in the proper way. We have to understand that it's not a waste to do preventive care, whether it's mental or physical or whatever, to help control chronic diseases so they don't become seriously acute. Currently, our hospital systems are going to be overwhelmed with the acuity of patients whose chronic diseases have never been properly controlled. And we have so much technology that will help us with that. We have more power in the system as a medical community than we realize, but it requires having trusting relationships among ourselves so that we can present a united front. It isn't about the hospital getting more than the doctor getting more than the hospital, and it's about all of us being able to practice excellent medicine.
Yeah, that's great. In a minute, we're going to circle up at our tables and spend some time working through some of the questions in the context of the framework, and we'll have those up on the screen. But I guess sort of final question before we break out into the groups, maybe if there's one sort of anecdote or story that you'd each be comfortable sharing in your own context that gets you really excited about sort of this idea of the redemptive frame at work in the context of what you do. Would love to hear that. Maybe we'll start down there and work our way back.
So the first, the anecdote that comes to mind, so we, again, at Hilltop largely focus on underserved families. So a vast majority of the patients that we see are on Medicaid, a good percentage are uninsured. It was actually a private insurance family that most recently opened my eyes to the reality of how a different frame in the way we sort of culturally deliver the care, like what is the culture of the delivery. We had a private insurance, new family, they had the Cadillac plan. I mean, it was the best plan. They heard about us and decided to come. And I sat with them and I talked to them. I listened to the health history that the kid had, and I did everything I'm supposed to do. I did my subjective, my objective, my assessment, my plan, all the cards, all the stuff, right? Nothing fancy. And at the end of the visit, I said, well, hey, we appreciate you being here. We're glad you're here. Here's what our follow-up plan is going to be. You can call us a B thing, whatever the tagline I'm supposed to say. And the family stopped, and the mom was just like, hey, I just want to tell you thank you. And I was like, thank you for what? It wasn't a complicated kid. They had some behavioral issues and things like that. But it wasn't a medically complicated situation. I had looked at the studies of the family feels like you're in the room longer if you sit in the chair and stand up and whatever, but we hadn't done anything special. And again, this is not a small child, this is an older child. So this mom had engaged the healthcare system for a long time, and she said, no one has ever listened to us. Mm-hmm. And you listened. And I just want to tell you thank you. And that hit me. We've been told that a lot by people that I expected to have never been listened to, right? If I'm seeing a refugee kid from Afghanistan who doesn't even know the concept of primary care, much less preventative care, they literally don't know what I mean when we say well check, we've had to do a lot of education. I understand that they've never been listened to. But for a family who within this system is supposed to be the top, to have felt like we've never been seen by the system, was sort of this moment of eye-opening of well, this isn't just about the underserved in our minds. This is about a whole system that just seems to have forgotten what its core was. Yep. And so it was a motivating factor of us, this needs to not just be about the refugee kids or the immigrant child. This needs to be about a broader addressed issue.
There's a couple things that come to mind. First, I would, with our families, like Reid was saying, when they go one of the specialized programs we have is a 10-week program. And it's about 50 hours of therapy during that program. And so they're going through some parent classes, and the parents are they're leaning in, they're bonding with the other parents, they have commonality, and we keep going, and we have sessions during the week. And around week 8, they all start to think, wait, the 10 weeks almost over. I have to go back to daily life, what's going to happen? And so they'll start asking in class, and I don't know how we missed this at intake, but they'll say, what happens after the 10 weeks? And our clinicians stay with them after the 10 weeks. We stay with them until they don't need mental health services anymore. We will refer them to somewhere if there's a specialty, but we stay with them. And I think that's where the redemptive piece comes in as well. Our model, because we struggle with Medicaid and reimbursement rates, any private practice clinician is not going to survive serving Medicaid, just paying their bills, caring for their families. And so our model is where every clinician that we have in the office, besides myself, they're all in private practice. And they contract with HALO to serve populations that are on Medicaid or underinsured or not insured, but they're also billing Blue Cross Blue Shield. And so every clinician just decides for themselves how many other families they can take. So that way they're walking away and being able to pay their bills and care for their families, but also serve in a very big way, which they desire, because that's why they became clinicians in the first place. One of the other small antidotes, we were doing some strategic planning and mission drift type conversations, and we were with the team, and we were asking that question about what would mission drift look like here at HALO. And the group finally agreed that we know we're off course if we don't have enough snacks. That was mission drift. And so it's just, that's the mindset. We need to provide everything that we can for our kids and our families. So.
Well, at the risk of this being a little dramatic, I would think for me and my experience, it was the Murrah bombing. We were the downtown hospital, and we had the most patients, all inpatient, outpatient. Within 12 hours, international media descended on Oklahoma City, and they're intense in terms of getting the story, and it's a very exploitative situation. We did two things that I'm enormously proud of to this day. One, all our doctors showed up. Nobody worried about billable hours. They all showed up, and they lent a hand where they could, as they were needed. No task was too mundane for them to undertake, and it saved lives, and it bonded us all together. The other thing we did was recognize that the mental health aspect of this was widespread and needed protection. We could have made huge, social capital by publicizing and boasting about all the stuff we did, giving access to patient stories. We did not do that. We were the only hospital that did not. We didn't release patient names. We advised people of what happens if you do an interview. We locked the hospital down. We developed a system so that families could come in without any hindrance, but everybody else was held outside. I have funny stories about that, but I won't go into it. But the whole thing is that we put our patients and their families first, no matter what. And we went in later and worried about how do we all get compensated for that. And I was really proud of that.
Yeah. Well, thank you. Reid, Cindy, Cynthia, thank you for sharing your experiences of how you're putting this idea of redemptive strategy to work. So it's great. We're going to,